We've heard this morning about love. We've heard Sir Bruce Keogh talk about the fact that we need to start doing things differently if the NHS is going to be successful in the future. And he talked a great deal about innovation. And we've heard about information being at the heart of everything that we do. And we've also heard about patient carers and how they themselves may be the subject of mistakes or human error. My talk today is called Rethink Patient Safety. Before I start, though, I just wanted to mention one thing. I just wanted to pay tribute to someone called Anne Bury. So Anne died in 2013. She was killed in Turkey. She was at the National Patient Safety Agency from the time of 2003 to 2009. If I'd come here last year, I would have paid this tribute to her. And I was reminded about her just the other day because the person who shot her was found guilty. So it reminded us all, the people that worked with her over those years. She's an awful lot for patient safety and quality, particularly in the north, and I just wanted to mention her. So rethink patient safety. What I'm going to do over the next 20 minutes is create the case for rethinking patient safety. I'm going to use 3 examples, and you can either disagree or agree with what I'm going to be saying. Thank you. So in order to do the research for this talk, I've spent the last 9 months talking to people, looking on the internet, and finding out as much as I can about what the state of play is. And I found in February 2015 this statement by Teja Gandhi. She announced a review by the National Patient Safety Foundation in the US, and a review that's going to be chaired by Don Berwick and Kaveh Shojania. And as she says there, this review is going to galvanize the field to move forward over the next 15 years with a unified view of the future of patient safety, to create a world where patients and those who care for them are free from avoidable harm. That's pretty much why we're all here today. This, in fact, is the largest safety huddle you can have in the UK today, and I would urge us all to do that, to connect with each other, to share our stories, and to share what we're learning across the next 2 days. But I would also urge us to have a think about what could we do differently in the next 15 years. So when I saw this, I actually got really quite excited. I thought, how wonderful would that be if somebody sat me down and said, do you know what, we could do all of this differently? And what would that look like? And what would you do differently? What would that feel like for you? So I'm going to argue the case for if you ruled the patient safety, what were the things that you'd like to work on? And 15 years is a really long time, and we have a lot to be proud of over the last 15 years, and we have come a long way. But I do think the time is right now just to press that pause button, and before we press play and move forward, we have a think about where we want to go. So those 3 areas. The first one is how are we learning, with the emphasis on how. The second one, what is the right culture for safety, and do we actually have it? And the third one is, are we implementing the right solutions? And the 2 key areas there are implementation and the right solutions. So I looked up Kaveh Shojania, the co-chair of this group, and I found a webinar that he'd recently given, and so had a listen. And very shortly after this webinar started, he said, incident reporting is the single biggest waste of time in the last 15 years. That took my breath away. He then went on to say, incident reporting is the most mistranslated intervention from aviation. And he described the fact that in aviation, in the main, they report the rare and the unique. And then that is then shared across the whole of the aviation industry, across the whole globe. And we don't have anything like that in the patient safety world. This is what it looks like in patient safety. So if any of you are holding the title risk manager or clinical governance manager or some sort of title like that, you'll have shared the experience that I had a few years ago. That's exactly what it felt like. I was at the top of a building, we didn't have an electronic system, and all of these forms would come flying into my desk, and they would pile higher and higher and higher. And what I was supposed to do was analyze them and try to understand what the state of play of my organization was. Was it safe or unsafe? What I was also supposed to do was identify which ones should I analyze and which ones should I not, which ones should we do a root cause analysis on and which ones should we not, and so on. So I focused on pie charts and trend data. I was very proud of those, and I celebrated the numbers going up, and we celebrated them at the board. But I do wonder whether I started to investigate the wrong things. Because Kaveh Shojania also talked about the fact that incident reporting is used for all sorts of wrong things. So incident reporting systems are now used for multiple areas: patient safety, clinical effectiveness, complaints, strategic issues, operational issues, and so on. He said, let's just take the issue of falls. The National Reporting and Learning System has consistently had falls as its highest number ever since it started over the last 10 or so years. Is it time that we actually stopped reporting falls via an incident reporting system? If you want to count falls, there are numerous very clever ways that you can do that. If you want to learn from falls, then I would suggest an incident reporting system may not be the answer. Because when we move on to things like root cause analysis, my experience of running a root cause analysis is that the people I speak to, sometimes weeks, if not months, and sometimes years after an incident, had extremely poor recall of what went on, what they did, and who else was involved. I spoke to a nurse who administered the wrong drug to the wrong patient. She had absolutely no recall of the details around that incident. We also don't know whether we're actually getting the truth or not, because we are biased by outcome, hindsight, and confirmative bias. We all know what those are, so we view an incident that may be identical to another differently because of the outcome. We often view incidents in relation to hindsight, and I've had it time and time again said to me that people will judge a person in front of them on the information they have on that day rather than the day that the incident happened or the time that the incident happened. And we like to choose things that confirm our own views about what's going on. But once we do that analysis and that investigation, we then develop superficial recommendations. We don't do that deliberately, we just do that because it's actually much, much easier to do. Then we ask those recommendations to be implemented across the whole system. And unfortunately, what happens is that as human beings, we revert to old practices really well. So unless you have actually designed out the error-producing conditions, or you've changed the system radically from the one where the incident occurred, what happens is that you erode that good practice over time. And in fact, what we've seen is fairly catastrophic incidents have happened in some organizations, and only about a year later, the same practices are still happening. So what we do is respond, and we say, let's produce a new protocol, let's tell people off, let's send them off to some training, or restrict practice or suspension. Those are the things that happened to me when I was involved in a drug error in the 1980s. I certainly was told off, I was sent off for some training, and I nearly was restricted from practice or suspension, but was told if I did it twice, I most definitely would, and if I did it 3 times, I would have been referred to my union. And what we do know from research is that the optimum time for learning is in fact in the 24 hours just after an incident. That's when we have the most recall. We won't know everything, but we have the most recall. And we can actually learn about what truly happened. And we can speak to the patients and or their carers, and we can try to figure out what went on. And that's well before the kick-in of a root cause analysis. So what would you do differently if you want to think about learning? What would you do differently in your roles of incident reporting and investigations? I love this picture. I'm very thankful to Tom Downs, who tweeted it some time ago. This is IHI, and they just ask you to measure your day depending on whether it's a good day or a bad day, and you use the particular counters in front of you. It's really, really simple. So I know that Sir Bruce talked about innovation, and he's absolutely right about talking about looking at things from a technical point of view and looking for some really clever ways of doing stuff. But also, sometimes the most simple things can help you count. And there are people across the globe who are starting to think differently about incident reporting and investigation. So there are people who are trialing things like two-stage reporting, where you'll have just an alert of the type of incident and where it was, and then for others to decide whether they should then take that forward for any further detail or review. There are others who are using case note reviews, safety huddles, so that you get to hear about incidents in real time and you can actually do something about them on the very day. Triage processes, call centres, rapid response teams who come flying in to try to help an organisation or a unit or a team when something's gone wrong. Or actually moving on to Sir Bruce's ideas around automation and some clever apps. These are all being trialled as we speak. So my second point, moving on from how are we learning, what is the right culture for safety? And I know I'm talking to a group of experts, and so you all know what this is. But unfortunately, there's an awful lot of your colleagues who don't. And we need to do something about that. This is a quote from some time ago, but I still think it's relevant for today. The single greatest impediment to error prevention is that we punish people for making mistakes. This is me on your left, quite some time ago, as you can see. And then on my right there is a nurse called Kimberly. So I was on PICU, and I was involved in giving 10 times the dose of the drug to a very sick child. And that sick child was made much sicker by that error. There was no incident report. There was no incident investigation. The parents weren't told about the incident. No one said sorry. And because I was in some way disciplined as a result of that incident, all of the staff were very fearful of speaking out. Now, this was the 1980s. And I thought that things had changed significantly since then. So in order to do this talk, I did a bit of a Google search. So I tapped in 10 times the dose into Google. Didn't say anything else. And up came incident after incident after incident. So over the last 20 or so years, the same thing has been happening time and time and time again to very vulnerable patients, an awful lot of them children. And one of these stories stood out because it could have been me. And this was Kimberly. So she was a pediatric intensive care nurse, and she gave 10 times the dose of calcium. So I had a look at the incident investigation, and this was what she said in her interview. I messed up. I've been giving calcium chloride for years. I was talking to someone while drawing it up. I miscalculated in my head, and I will be more careful in the future. That tells us two things. It tells us where her head was. She definitely thought this was all down to her. And it also gives us some indication of why the mistake was made. Often they say that when you do something very routinely, you can start to make errors, even though it's something you've done time and time again. She was clearly distracted or interrupted, and she may well have been thinking about something that somebody distracted her about in terms of that talking to someone. And I would imagine it was probably very important. She miscalculated in her head. So let's go back to Sir Bruce Keogh's talk. There is absolutely no reason why we should be using calculations in our head in terms of giving very complex drugs to children. But I will be more careful in the future is most definitely not a recommendation for sustained change. Sadly, Kimberly was so traumatized by this incident and the fact that she was suspended from work and isolated from her colleagues, she committed suicide. That drew my breath away because, as I said, that could have been me. So I think that everyone in this room should agree on 3 things. The best people can make the worst mistake. The systems will never be perfect, and humans will never be perfect. Because if we have that mindset, and if we expect to administer 10 times the dose, or we expect to operate on the wrong leg, or we expect to give patients the drugs they are allergic to, we will have that preoccupation with failure rather than counting where we have failed. So the right just culture is one that combines that just culture philosophy, continual learning, design for safety, procurement for safety, and resilience. So this brings me on to the avoidable versus the unavoidable. I'm not going to ask you to stick your hands up, but I suspect some of you in the room may have been to one of these meetings. So up and down the country, some nurses are asked to come together around a large board table. There's usually about 30 or 40 of them. They come clutching their notes, and they come clutching a sense of fear, because what they do is they have to sit in judge and jury and explain as to whether the incident they are involved in, which is usually a pressure ulcer, but it can be something else, whether that incident they are involved in was avoidable or unavoidable. And they're all hoping it's going to be unavoidable, because if it's unavoidable, then they won't be blamed and their team won't be blamed and all will be fine. So you can bet your bottom dollar that all of the cases that are told before them are not listened to or heard, and all of the cases after them are not listened or heard, because they're sitting saying, phew, that's over for me. So when we talk about how are we learning, and we talk about the just culture, this does not seem a particularly good way of doing that. The other thing we have is people saying, and often these are quite senior, don't bring me problems, bring me solutions. Sometimes I think they think they're being quite clever. This really worries me, because actually what this does is instill fear in bringing problems until you've got the solutions. But as we know, patient safety is hugely complex. And what you actually want to do is bring the problems so that you can work together on the solutions and you can get help. So I would like us all to agree that the just culture is where people who make an error are cared for and supported. The people who don't adhere to policies are asked first before being judged, and people who intentionally put their patients or themselves at risk are accountable for their actions. Because we're not talking about a blame-free culture, we're talking about a just and fair culture. So if we rethink and design our human resource policies around the human error and comforting, supporting, and consoling, the seeking to understand risky behavior and disciplining reckless behavior, we will truly have a safe culture. So which moves me on to my third point. What should we do differently for the next 15 years in relation to implementing the right solutions? We all know that there's a theory and a gap between that and practice. And there's some research that shows that that takes anything between 10 and 17 years. So some research made today may not be embedded and sustained in practice for another 10 or 17 years. I'm sure there are ways that we could make that quicker and smarter, but let's live with what we know from the research at the moment. So the crucial important thing here is that successful adoption of interventions requires us to know why and how they work. So coming back to the how of learning. And there are an awful lot of academics who are really exercised with this at this moment, about understanding why and how. So when you hear stories of success throughout the next 2 days, ask yourself, how did they do that? How did they come across all of the challenges they faced? What resistance did they get? What support did they get at board level? What were the things that made them more successful than maybe someone else? Ask how. This is the science of implementation. So I was really excited to find out that I'm not alone in this whole desire for thinking about things differently. There's a new series in the BMJ Quality and Safety, also led by Kaveh Shojani, his name's cropping up again, and Ken Catchpole, and it's called The Problem With. And they're going to look at pervasive problems that seem to resist solution. So I think that that will be a really good series to have a look at. And they have listed things like incident reporting, and the first one that they're going to look at is on checklists. And they talk about the problems with solutions as focusing on a problem out of proportion to its importance, failing to appreciate the complexity of a problem, and using strategies that actually sound like solutions but haven't been worked out, so are really unsolved problems, like changing the culture and sorting out the teamwork. So the problem with implementation that we found out is that it's often inadequate. It takes much more effort and expertise than is generally recognized. It is not simply telling people to just do it and off they go and will. That unfortunately, frequently, it fails to deliver in practice. But crucially, we convince ourselves to keep carrying on when the solution may not be the right one. So coming back to rethinking where we are now, where we've been in the last 15 years, and where we want to be in the next 15 years. So as I say, the first one they've looked at is the checklist. And it's an incredibly good review of the good, the bad, and the ugly associated with the checklists by Ken Catchpole and Stephanie Russ. Now, all of you over the next 2 days are going to hear from wonderful speakers on all of these great issues, these issues of avoidable harm, such as acute kidney injury, medication safety, deterioration, falls, sepsis. Every one of you will have people in your organization who is the champion for these. And they are passionate, beyond passionate, about getting this right. But what they are doing is slightly competing against each other. And sometimes if their voices are louder than others, they get heard more than others. I would also argue that there are some cross-cutting themes that run through all of these harmful situations. These cross-cutting themes are perhaps the things that we should start thinking about, and they've been mentioned already today. So most incidents and most investigations come up with the following 5: information, communication, observation, design, and relationships, again, has also been brought up this morning. So my mum went in for a hip operation a few years ago in her 70s. Preoperatively, she told them all that she was on aspirin, number 1, and number 2, she was allergic to opioids. This wasn't a simple allergy. This was where she collapsed and her blood pressure dropped and she really was quite unwell. So she informed the healthcare staff, who quite duly said, "Thank you very much, all noted, keep taking your aspirin, and we've noted the opioids and we've put that in your notes, so don't worry about any of that." She went in for the operation, she came out, and I went to visit her on that same evening. And what I found was a very, very pale, very confused, disorientated, and decidedly sick-looking mum. She wasn't looking like my mum at all. So I had a look at her observation chart. It was beautifully completed, with the blood pressure consistently going down hour by hour by hour. I looked at her drug chart, and I could see that she'd been given some opioids and her antihypertensives. So through some great long and pushy conversations, I convinced them that she didn't need the opioids and could they find a different pain relief, and that perhaps they should have stopped the aspirin because I can see that she'd bled quite significantly, and that maybe not to give her antihypertensives in the morning. Thank you very much. Left for the night, came back the next day, and as I walked in, one of the nurses said to me, "Your mum's had a bit of a funny turn." So I found her yet again collapsed and looking really quite poorly. So we had a long conversation. Apparently they changed her drug, her pain relief, to a drug that was brand new and the latest thing. And they didn't think it had any opioids in it. But when we looked at the information sheet, we found somewhere hidden in there that it actually had a component of opioid in it. And they had still given her antihypertensives, because we're very good at doing the routine. So we'd informed them, they hadn't really listened. We'd communicated, and they hadn't really listened. They'd observed, but they hadn't really followed that through. And actually, I think they could have designed out the system so that she didn't have the drug that she was allergic to. There must be something clever that we can do to prevent that. And ultimately, also, it was about relationships. Her trust in the healthcare providers. She believed them when they said they would note that she was allergic and they wouldn't give that drug to her. I trusted them that they wouldn't do it again. But those relationships were repaired by us working together in partnership as to figure out how we could make sure it didn't happen again. And it didn't. And thankfully, my mum went home a few days later. So Mary Dixon Woods then talks about, are we standardizing where we can? And I think, again, this comes back to Sir Bruce Keogh's talk, because I do think there are very clever ways in which we could standardize what we have in the NHS without people feeling really vulnerable or protective about what they do. This in itself, it always drives you mad when you buy a new phone that you've got to actually buy a new charger at the same time. But we do this in healthcare an awful lot. This is thanks to Ross Scrivener, who posted this picture on Twitter a little while ago. So this anaesthetic machine looks brand new to me, but as you can see, the suction machine is incredibly close to the anaesthetic machine on and off switch. And the suction on and off switch is a little bit further away. So you can see how clearly that is setting someone up to fail, to switch off the anaesthetic machine when they were hoping to switch off the suction machine. If this is a brand new kit, then I'm incredibly surprised that somebody hasn't done something about that before it got to the point of procurement. So I think that we need to rethink solutions by reducing harm topic by topic, of course. That seems an important and right thing to do. But also, at the same time, kind of surround that with a relentless focus on the cross-cutting factors, those things that I mentioned, the information, the communication, and so on. Then be really clever about how you can design out error. Design out your processes, design your equipment, your wards, your hospitals. Design them for safety, and we know that that can be done. Let's procure the same things across the NHS. Let's make use of the fact that we have an N in the NHS and that we use the economies of scale and procure the same thing to be used everywhere so that anyone brand new on the unit can use the same piece of equipment. So standardizing equipment, care processes, reducing handovers and reducing waste are all part of that whole rethink solutions. So I'm leading a campaign with a most wonderful group of people called Sign Up to Safety. And our promise is that we're going to help you over the next 2 years left of the campaign about how we're learning, about the learning approach that we're doing in the NHS, and we're going to do that in numerous different ways. We are also going to help you by promoting the right culture for the NHS and role modelling what that looks like, and talking to policymakers and system leads. And we're going to work with knowledge creation to really figure out what is good implementation of the right solutions. And we're going to kick that off with a summit of the senior leads and the experts in the topic areas that I've mentioned earlier: acute kidney injury, sepsis, falls, and so on. And we're going to bring them together and we're going to work out what are the commonalities. How can we stop competing with each other? How can we actually work together and share all of that across the whole of the NHS? Because stopping or doing things in a very different way always sounds like such a big deal. It sounds like something that should be approached in awe and done only once or twice in a lifetime. So I think 15 years is quite a long time in order to wait before we actually stop and really think about what we're doing in patient safety before we go on for the next 15 years. Because I would argue otherwise. Stopping or rethinking patient safety is a very wise thing to do. So Sign Up to Safety will help you. The time is now. Thank you.